Thank you very much, gentlemen, for making the discussion this afternoon. And I think the focus and the area that we'd like to touch on for this panel discussion is around what does the future funding for healthcare look like, and what does it also look like from a crisis response perspective as well. And maybe if we can start the conversation a little bit with TESHLIN, given the presentation that he's put forward. What are potentially additional to the sort of telemedicine and the home care pieces? What are some of the other innovation models that are coming through that can help from a funding perspective, with the ultimate aim of driving quality healthcare across more individuals within South Africa?
Thank you for the question, Thailand. I think there's two parts, if I just look at broadly speaking, that I've seen adequately address the problem that we have. More recent, the wellness type of offerings that actually incentivizes people to take care of their own health rather than just rely on the healthcare system to support their health is actually quite key. It's enabling more and more people as using reward mechanisms to get healthier, stay healthier, and alleviate the burden of healthcare systems across the world. So I think that the popularity of that is going to be quite important, how people actually play out into that. If you look at the financial services sector of South Africa, we have one of the most advanced financial services sectors worldwide, whether it's the insurance side, whether it's banking, whether it's our schemes that we have. It's quite advanced in terms of the regulation that governs it, and in the ultimate aim of protecting consumers and clients alike. The innovation that we're going to see in the future is how people use our financial services sector to co-create these products and weave these products to actually deliver a health outcome. We've been quite siloed. If you look at banking is siloed. Loans, savings, transactional banking is quite siloed. Same thing with insurance companies, car insurance, life insurance, health insurance, quite siloed. And I don't think we've broke down those silos to adequately deliver innovative solutions. Some companies have tried to do that. They've tried to integrate their solutions. We're in a world that you're going to have to use multiple licenses, multiple vehicles at your disposal to meet a healthcare outcome. So I'm looking forward to that part of innovation, how the financial sector, services sector is going to be disrupted.
Thanks. And apologies, I did not introduce our fifth panelist, Dr. Michael Kilpin, who's a private surgeon and also head of WITS Medical Bioinformatics and Translational Sciences. Welcome, Doctor. Perfect. I think just maybe moving on from the conversation around the funding perspective, COVID-19 has been this massive disruption that we've seen in the last sort of 18 months to 2 years. And this is also forcing us to think of new ways and to kind of drive, more innovative solutions. And one of the areas is looking at digital health and how does that seed look like from this perspective. And, I'd like to bring in Dr. Eashwari at this point to say, how does the Department of Health look at how they plan and they build into their strategy a sort of digital health platform or a digital health approach for the years to come? Sorry, Doctor, I think you're still on mute.
Thanks, Thandran. At a strategic level, I'm sure there are a lot of plans that are happening at a much, much higher level. But what I'd like to pose a question to the listeners and to the other panelists is: when you walk into a coffee shop, before we order a cup of coffee, we ask them, "Do you have Wi-Fi?" I think that is quite key in what I'm trying to say just now. It's because if you don't have connectivity and if you don't give access to the common man, it will be impossible to achieve, even though there might be billions of rand that gets allocated. But if you don't look at the basic facts, especially at the last mile, I think it's important that we have that kind of vision to make it work in the favor. Like TESHLIN was saying, we have to keep people healthy. Even for NHI to work, if you ask me, we don't want people to fall sick and come to our facilities. Then we spend a lot of money on managing the complications of diabetes and hypertension. What I would like to see happening is to have citizen information available across the continuum of care. And if you are able to pick up early diabetics and early hypertensives, we achieve more than what we can actually in managing the population better and reducing the cost to manage them when they land up at our facilities. I'd like to stop there. I'm sure my colleagues will have better understanding of than mine on the financing part of it. I'm looking at more a practical part of it, especially when it comes to the last mile. Thanks.
No, perfect. I think those are challenges that we can, overcome with collaboration with the various telecommunications networks, technology partners that exist, cloud infrastructure, individual companies within South Africa. And maybe if we shift it a little bit more to a individual perspective and a training perspective, and Dr. Kilpin, Dr. Cruz, if you can maybe come in at this point. There was I was part of a session some many years ago with some professors from Wits, where they were looking at how do they develop an e-research master's program. And the main premise that drove that particular new program was to say an archaeologist previously used to ask for a hammer as part of their tool set. That's what they needed as part of their equipment. And now in this digital age, they're asking for more sophisticated X-ray equipment that can actually survey the underground without having to go through, massive amounts of earth and unveil all of their pieces. And that kind of changed the mindset around how do you train and equip the individuals at a tertiary level to come into the workforce and be well prepared. How are the tertiary institutions focusing and driving the skill sets that are going to be there today, or that are there today, and that are going to be needed in the future to drive the type of strategy that Dr. Rajeev is talking about? Maybe Dr. Cruz first, and then
Right, very quickly, and thank you very much for asking me to join the panel. You may know that I've been teaching a course called How to Future-Proof Your Healthcare Practice at the Henley Business School for the past year. So some of the insights I'm giving you are things I've learned from teaching 100-plus practitioners in South Africa in the past year during the COVID crisis. Now, one of the key things we learned from COVID was, and it will go back to Dr. Eashwari's point, during this pandemic, our clinicians generally behave very well in the emergency situation from a clinical point of view. Where they were let down was on the administrative side by what we would call the back office, supply of staff, PPE, ventilators, equipment, all that sort of stuff. And so one of the reasons that I think this happens is, and I've actually designed another course called What They Don't Teach You at Medical School. And I think, to go back to Dr. Naidu's point, the medical schools don't teach you anything about how to run a medical practice, budgeting, HR, hiring staff, medical aid, all that stuff that you need. So this is the message that's coming from the clinicians. To quickly answer so we can fix that by getting medical schools to twin or work jointly with business schools. And this will include nursing colleges, allied health science faculties, because we have many practitioners who are not medically qualified. So that's one quick point. Another quick point that emerged from the courses was that there are new funding models. I recommend an article by Julia Adler-Milstein in the August New England Journal of Medicine, which is titled Paying for Digital Healthcare, and it answers some of the questions. The bottom line is capitation. We don't have many capitation models in South Africa. We're still too fee-for-service based. And the conclusion of her article is that capitation models will enable various other funders, including corporates, NGOs, and the government, possibly through NHI, to make small regular payments to clinicians, which are not going to break the bank, but which will give the uninsured some level of coverage. And so a little bit like the NHS, where there's a kind of fee per capita every month. Another good idea that's emerged from South Africa this year is that both Discovery and Momentum have invented a voucher scheme. This is for uninsured people. An employer can buy, or you can buy retail at a petrol station, a voucher for, let's say, 200 Rand consultation, which is a lot less than the medical aid rate. And people who have no health insurance can be given these vouchers in order to get a limited form of consultation, including basic medication. So these are two, I think, great ideas: capitation and other methods of payment, including voucher schemes. Thank you.
Thank you, Doctor. Dr. Kilpin.
Thanks for the invitation to chat, and just to a couple of overarching points, and then maybe just address some of the issues that Dr. Cruz and Dr. Eashwari mentioned. So the first one is I agree absolutely that the clinical staff in South Africa, both in the private and the public sector, performed exceptionally well during the various peaks that we had, and to a large degree, the infrastructure requirements were, where there was room for improvement. But I do think the other lesson is that has been learned all over the world, and that what we need to remember in South Africa is that technology is not a solution for a dysfunctional process. And South Africa has a very comprehensive and well-written document on its e-health strategy, where it freely acknowledges the issues around capacity building, lack of domain knowledge, poor support, poor ability to support. But the reality of it is that as a clinician, I can tell you now that the functionality in both private and public healthcare sector, there's significant dysfunction. There's a significant amount of dysfunctional process. And no matter how much technology is layered on top of that, it's not going to solve it until the process itself is sorted out. The other thing from the point of view of training and the kind of what one would call kind of e-training or e-savvy or tech-savvy or IT-savvy, classically, the humanities and the clinical sciences are probably the two faculties that have probably been left behind in terms of their curricula and the amount of attention that has been paid to the use of information technology in those arenas. And to some degree, that has been improved by what is the graduate entry medical program model, whereby students who have other undergraduate degrees can be admitted to study a degree in medicine. So that would, and ideally one wants to look at developing capacity within the STEM type specialities, the science, technology, engineering, and maths, which is what is really, really lacking from the curriculum from a clinical point of view. Lastly, just to reply as a surgeon who practices actively in the private practice and has more than 20 years experience in the public sector, there's absolutely no doubt that the present models of fee for service are absolutely a not sustainable model. However, the issue around about a centralized money pot, for want of a better word, administered by government is unfortunately both a political, social, and healthcare hot potato. And I think that we need to acknowledge that there are significant issues surrounding that in South Africa, and that they're not unsolvable, but the first step towards it is an open and honest understanding of the resistance towards any form of another pot of money under control of what is perceived to not necessarily have the country's best interests at heart group. I know that's quite controversial, and it is a bit of an elephant in the room, but like it or not, that's the reality of life in South Africa at the moment. Thanks.
No, thank you, Dr. Kilpin. So maybe Dr. Kibe, just to kind of bring you into the conversation, how do you find these challenges that we're looking at from a South African perspective within Kenya? Do you resonate with many of the issues and the points that have been raised here, or is it a different kettle of fish that exists within your ecosystem, in your environment? Dr. Wathugi, are you there? Okay, I think there might be some connection issues. So maybe just coming back to what you mentioned as well, Dr. Cruz, in terms of the capitation models, and maybe posing this back to TESHLIN, how do we see that relationship between the provider and the funders growing to develop more alternative reimbursement models to improve or to increase the number of individuals that come through the healthcare system? What's your views on that?
Look, I think it's a great question, so thank you for that. The theme that has been thrown around worldwide, I think, for the last 10 years is actually value-based care, right? How do you incentivize outcomes and reduced complexities as a result of the healthcare provision, and going into a ARM, or alternative risk model of sorts, that actually capitates the cost of the provision of healthcare. And I think that those models will start to develop as we go along. I think there are lots of conversations going on right now worldwide. It's not just in South Africa. And the sooner we actually start embracing those type of models, the better it is, because it starts aligning all interests, right? It aligns the funder's interests, it aligns the patient's interests, as well as the healthcare provider's interests. And it just gets accountability to a level that's second to none. So it's something that's going to take off in the years to come, whether it's in South Africa or worldwide. Value-based care is here to stay. And I think it's good for all stakeholders involved.
Yes, Dr. Cruz?
Very, very quickly, to your point, TESHLIN, about 15 years ago, there was a very good study done by the Nuffield Foundation in the UK from a Professor Einthoven, who is a Stanford University health economist, and he was asked one question: what's wrong with the NHS funding? And his answer was interesting. He said that the one-line answer is that resources do not follow the patient in the system. And that partly meant there was no proper measurement or accounting of clinical encounters, no measure of consumables and staff costs and so on. And the interesting example, which I know because I was a consultant at the Royal Free Hospital, where a centre of excellence develops under these models, other health authorities, the example was haemophilia at the Royal Free in London, they lose cost by transferring all their patients to the centre of excellence. So they remove their clinical risk, the patient, and the cost. So what happens to the Royal Free? It sinks, because the more good they get at clinical excellence, the worse they get financially, because they get overwhelmed. So Einthoven's solution was put a £500 notional note on the forehead of every patient, and then watch people compete for that resource, even if it's virtual. I mean, it's not real money, it's virtual money. So centers of excellence would have an incentive to do more work and develop more capacity, and those who are not interested in that would simply not compete for it. So that's one of the solutions. The other solution, back to Dr. Eashwari, we've got a wonderful opportunity in Africa through mHealth. And I think, the Wi-Fi and the mobile, even if it's an Android and, not very advanced, is the secret. Just as it's revolutionized banking in East Africa and West Africa and is taking off here in South Africa, mMoney, mHealth, I think, is how we extend health to those who have been marginalized and basically uninsured and have no access. And so apps and mHealth options, I think, are part of the solution for us in Africa.
No, thank you, Dr. Cruz. Dr. Wathugi, are you there? Can you hear us? Yes. So maybe just to bring you to the conversation, what are some of the sort of innovation that's happening within the Kenyan health ecosystem, and maybe some of the challenges that you are facing, or that the challenges that individuals within that ecosystem are facing?
Okay, thank you very much, Theandran. Thank you, my fellow panelists, and to all the guests who listening to us. In Nairobi, Kenya, pre and post.
Hi, Doctor. It seems your connection is a bit unstable. Maybe just for the purposes going forward, if you can switch your video off, that should help with the connection on your side. Okay, so I think while...
Diabetes and hypertension.
Sorry, yes, we can hear you.
Yes, am I audible enough?
Yes, sir, we can hear you now.
Okay, so I was talking about the electronic medical system that we've been using in management of diabetes and hypertension. The system is basically built on an open MRS platform, meaning that it can be just without so much hindrance. It's easier to upgrade and use, and it's more of a clinician end-to-end platform where we are able to comprehensively take care of the patient from the demographics to the quick treatments. We are able to monitor their adherence to and compliance to medications. We are able to book them for appointments and review. And at the same time, the same platform is able to offer health promotion through education platforms such as text messages and WhatsApp messages that are sent directly to the patients. Now, how this came into use and help us during the COVID-19 pandemic, which really caused a big challenge because there were lockdowns, there was limited movement of patients. There was not enough data, especially on those with comorbidities and accessing the healthcare services. But then using this platform, we were able to map out the patients based on their geographical locations. Since we already had their telephone numbers, we had next of kin, we had landmarks and pin drops of where they live. So we were able to follow them up, and then we used a differentiated care model whereby we were able now to use the community strategy, that is through the community health volunteers, to be able to reach out to the patients to have their blood pressure checked, their blood sugars measured, to supply them medications so that we do not have erratic supply for the same. So the system, I can say, is very helpful. And the beauty of it is that it's accessible through an Android application or a web browser. So what we do is that we are able to create credentials, because again, the issue of patient confidentiality is very, very important, especially when you're using these virtual platforms. So we have an end-to-end encrypted system where the clinicians have specific login credentials which are pinned to their geographical position, that is the GPS. So they can only be able to access patient information for the patients that they are taking care of, not unless then there is a referral which allows you. Again, the model is able to engage with the patient so that they are able to give authorization or a consent that yes, they've agreed to be managed by a certain service provider, be it a doctor, be it a nurse, or whoever is attending to them. Yes, and I think what maybe you asked me about some of the challenges that we've been having is that in our country, especially during these COVID times, we had a lot of initial limitation in movement, and then after the lockdowns were uplifted, most people tended to travel up country. So we had a lot of problems trying to work on identifying where our patients have gone to. Are they able to continue with their care? If they are continuing with their care, we needed to know which facilities are they seeking care. Are we able to get in touch with the service provider on the other end and to share the information? How was this patient? What medications have they been using? If it is their glycated sugars, for example, how have they been? Are there procedures that were waiting or pending that needed to be done before they moved or moved to the various other facilities? However, it's important also to say that this has not just been a government approach. We've worked with our various partners, including private institutions. We've come together even with some of the internet service providers, the mobile telephone companies, some institutions like Intellisoft Consulting. So we've formed a synergistic team of not just medics. So we have the private insurance companies, because some of these clients, they are either doing out-of-pocket expenditure, or they're using the government health insurance scheme, or they have a private insurance. And nevertheless, we try to create a system which is able to address them regardless of what kind of service they are able to seek. Is it in a private facility? Is it in a faith-based facility? However, I can also say that funding, right now as a country, there's a lot of dependency. There is a lot of reduced donor funding, although specific to some disease conditions like HIV, TB, and malaria, but we are seeing the same happening even in other disease programs. So it's the high time that the government commits more to health financing, and also the community needs to be more aware that in terms of these pandemics and natural disasters and outbreaks, then they need to be cushioned so that there is that continuum of care, especially when you're talking about patients with chronic illnesses which require long-term medication. Thank you.
No, thank you. Thank you very much, Doctor, for that perspective. I think maybe, Dr. Eashwari, just coming back to you in terms of the portfolio that you lead within the department, and given some of the points mentioned around mHealth and some of the technology, what are some of the initiatives and programs that's currently being run by the department to support eHealth and mHealth solutions going forward?
Thank you very much for that question. There's quite a few things that are being planned, but very few initiatives have actually taken off the ground. One of the things that as Gauteng Department of Health we have done is there's an app that has been developed. It's called Impilo app, MPILO. It's on the public domain. You can actually download it on your phone, and then you can access the Impilo app. It gives real-time information to patients to find where the facilities are, and they can book an ambulance, and they can track the ambulance as well, apart from other features that has. But I think what is important going forward is we have to make sure that the citizens are kept healthy, and instead of reinventing the wheel, the initiatives going forward should be public-private partnerships or public-private initiatives where we can look at the models that has been developed by the likes of Discovery and Momentum and others who have a very good wellness map. And then that's something that is required going forward. And we have to look at cloud-based services. We are not there as yet, but I'm sure going forward, we have to digitize clinical records of patients, and the information should be shared across the continuum of care, both in public and private sectors. And if you are able to do that, then it's possible to achieve what you're trying to achieve. But if to answer you, what have we done so far for using technology? I think we are still in the planning phase. There is a national digital health strategy that has been approved, and there is clear-cut direction in the strategy. We have health normative standards framework that guide us on interoperability issues. All that is there, but we still have to operationalize it. So that is where we are at this stage. We still have to do a lot of work. And I believe there is an opportunity talking to the industry, talking to academics, and then try and see if we can get some international or non-governmental funding that can actually assist us. Because the question that you asked earlier was, is there any funding allocated for telemedicine or any kind of digitization process? I think we are a little bit slow on allocation of that funding. But I'm sure my colleagues know better than what I'm saying. But I think there is an opportunity if we work together. Thanks.
No, thank you. Thank you very much, Doctor. I think we're coming up to time, so I'm just going to give each panelist, a minute just to provide some of their concluding remarks, and maybe if we can start with Dr. Kilpin.
Thanks to everyone. I think that Dr. Eashwari kind of more or less hit the nail on the head there, is that the technology does require an investment, and it requires an infrastructure, it requires hardware, it requires software, it requires process, and it requires people. And one has to understand that we tend to live in the world of WhatsApp, where we think it's free, because we don't pay for WhatsApp, we don't pay for Facebook, we don't pay for Gmail, call it what you will. But the bottom line is that any form of technology infrastructure requires a significant investment. And if you're not paying for it, you're paying for it if you're not paying for it in cents, you're paying for it in data. Yeah. Thanks.
Thank you, Dr. TESHLIN.
No, thank you. Thank you for having me on, both as a speaker and a panelist. I do look forward to the years to come, in all honesty. I think we're at the cusp of changing healthcare as a whole. And I think there are lots of bright minds actually looking at how we revolutionize the access to care across the public and private sector. And I think what's going to actually move the dial is those partnerships, whether it's vertical supply chains or whether it's through public-private partnerships. We need to, in all honesty, put our egos aside and see how we solve a problem a lot bigger than all of us. So that's my honest opinion. So.
Perfect. Thank you so much. Dr. Wathugi? Dr. Wathugi, any closing remarks from your side? Okay, I think we're still having some technical issues. Dr. Cruz?
Thank you. Very briefly, appreciate again meeting you all and being online. From the lecture, the virtual lecture theatre, I agree 100% with what Dr. Eashwari has been saying and with Michael and TESHLIN. The future is with us. The digital side of it is absolutely vital. The cloud is where the data will need to reside. And a quick anecdote, 2 of our medical practitioners lost their medical practices in the looting of Gauteng in July, but they had attended our course in March and they had migrated their data to the cloud. Can you imagine? So they were able to regenerate. A third doctor was held up at gunpoint in his practice in Gauteng, and all his computers and phones were stolen. And he was able also, because he'd been on the course, to recreate it from the cloud. So the cloud is where the solution lies, but we mustn't have head in the clouds. It's got to be feet on the ground. And the cloud is a powerful metaphor. We're not daunted by the future, but we're not shackled to the past. So we look forward to working together with all the sectors, particularly with the government sector and the rest of Africa. Thank you.
Perfect. Thank you so much, Dr. Cruz. Dr. Wathugi, any closing remarks from your side?
Yes, thank you, and thank you for the opportunity. As we come to wind up, I think Dr. Rajeev really well articulated the issue of interoperability between the various applications, because it's been one of our major challenges, because we realize that different partners, different stakeholders have different solutions according to the settings or the space in which they are working. However, I think there is need to see how, by leveraging more on in terms of information and technology, how can these platforms be able to communicate to each other? If I, for example, get some technical issues trying to put up my presentation, how then is it possible to be able to have, a common ground where various platforms can speak to each other, where I can be able to, make a telemedicine phone call to my colleague, Dr. Peter, wherever in South Africa, and then we can share some information. I can see some insight and say, yes, again, at the minimum cost, both to the clinician and as well as to the patient, so that it becomes affordable. And I truly agree with all the panelists and the discussions that we've had, that we need to make this space affordable and accessible to as many users as they, so that we're also able to get real-time information, which helps us in making timely decisions, which again improves the outcomes and have a positive impact on the life of the people that we are serving. Thank you so very much. Thank you very much.
Perfect. Thank you, Doctor. And I think maybe just to sum up, the conversation, I think, we keep talking about the future of healthcare. I think the future of healthcare is here already. And there's technology enablers, there's process enablers, and there's a lot of lessons that we can adopt from the first world and adapt to in South African and African context. Looking at how progression and innovation has been embarked on and tried and tested across the world, how do we leverage that thinking and don't reinvent the wheel? You know, things like data virtualization, being able to connect to these interoperable systems and have a single view of a patient to provide that longitudinal analysis or that longitudinal view, so that any physician that a patient then visits has at their fingertips the ability to understand a full patient history and provide the level of care that is required. So I think there's some very exciting opportunities and very exciting potential to collaborate, both public, private, technology and services individuals would all have the same aim at the end of the day, is to how do we improve patient outcomes, how do we ensure that the masses within the continent have access to quality healthcare, and that can also change their lifestyle so that there's no need for them to come into a healthcare facility. I think that's the main objective that we should all strive for. So thank you very much to all of our panelists. And we look forward to day 2 of the session, where we'll continue the conversation, and look forward to having you on this platform again. So thank you very much for joining us.
Thank you.
Thank you. Goodbye.
Thank you.
Thank you.
Thank you very much.
Cheers, guys. Thank you.
Perfect. Thank you. Thank you very much to our panelists. I think it was a very, very interesting discussion. I think there's a lot of talking points that would come through. I think, and urge more participation from